Almost a third of U.S. adults now report symptoms of either depression or anxiety, which is roughly 3 times as many as just in 2019. There has also been an alarming increase in mental health problems among adolescents. At least 1 in 5 young people between 10 to 18 years old struggles with a mental health disorder. Nearly 20% of high school students report serious thoughts of suicide, and 9% have made an attempt to take their own lives. These are obviously serious increases, and these are deadly issues. So in recognition of September as Suicide Prevention Awareness Month, let's take a look at these issues and this topic and what we can do about it. And to help us get a better understanding, I'm joined by Dr. David Jobes. Dr. Jobes is a professor of psychology and associate director of clinical training at Catholic University of America in Washington. He's the director of the CUA Suicide Prevention Lab. He's also served as a research consultant to the CDC, and he's been a consultant to the Institute of Medicine of the National Academy of Sciences. He's also worked with the National Institute of Mental Health, the FBI, the National Security Agency, the Department of Defense, and the Department of Veteran Affairs. Dr. Jobes is the creator and developer of a treatment called CAMS, Collaborative Assessment and Management of Suicide, which is the focus of his most recent book, Managing Suicidal Risk. It's the 3rd edition. So good to be with you, Doctor. Thank you very much for taking the time.
Thank you, Governor, for having me. I'm really delighted to be with you.
Doctor, according to the CDC, over 49,000 people died of suicide just last year. And with the exception of a brief dip, apparently in 2019 and 2020, which I want to ask you about, the rate of suicide has steadily increased. 2 questions. First, the dip in the suicide rate during 19 and 20, which some say is attributed to some sense of solidarity at the beginning of the COVID pandemic. Do you ascribe to that theory? Why a dip in 2019, 2020, just when the pandemic is starting?
You know, I've looked at this a lot of different ways, Governor. My feeling was that was a possibility. You know, we've seen, like at 9/11 and during previous wars, that suicide rates have dipped when there's a national sort of moment to unify. And so that was a possibility. And there was also concerns with the pandemic of isolation. And so a lot of people in my business kind of tried to have it both ways, saying, well, it could go up or it could go down. I was surprised, ultimately to see it dip for those 2 years, but then unfortunately we've had the highest raw number that we've had in the most recent provisional data from the CDC.
Yeah. People in my business like to have it both ways also, Dr. Jobes. But that is interesting because at the beginning of the COVID pandemic, I do believe there was a moment of solidarity and a moment of almost national unity, apprehension, but there was energy in that moment. That's why I asked the question. But besides that dip, then you just have an increased rate. What is driving that?
It is no one knows. And so what I can say about it is we've just had this steady march over the last 3 decades where you've seen other leading causes of death actually trail down. HIV is a great example where it was a leading cause of death in the 80s, as you know, sir, and then it started dipping down as research started to address the issue. I think a lot about the military, who I've worked a lot with over the years, where it used to be protective to be in uniform. And they would have lower rates of suicide compared to age and gender matched cohorts. And that was true after 9/11 and for the first several years after we got into the 2 separate wars in Iraq and Afghanistan. And then it started marching up. And it eclipsed the civilian rate and just kept on marching up. And it remains high to this day. And we don't know exactly how or what that's about, especially service members that are dying in garrison who aren't even necessarily deployed or in combat environments. So it's the mystery. Sociologists will weigh in, anthropologists, psychologists, psychiatrists will weigh in. But there certainly is this steady march that is very concerning, even though public awareness and like a podcast like this has, in my experience in 40 years, we've really seen a major level of interest the last 5 or 10 that's been, so out of the ordinary.
Doctor, 79% of the total number of suicides in 2020 were men.
Yeah.
What is that about?
Well, men are tricky. Middle-aged white men is really where the body count is, to be crass about it, and it is alarming. There are very significant gender differences. Women attempt suicide in ways that men don't, and men die by suicide. A lot of the hypothesizing is around firearm ownership and knowledge, access to firearms, which is the number one method choice in our country. A lot of it can be thought to be connected to performance and achievement. And of course, men are in our culture, are very performance oriented. So we don't know. I mean, everybody says they know, is speculating as much as anybody, but we do see robust gender differences that have been concerning now for decades.
The connection with firearms, is it that people who have a firearm choose to use a firearm and more people have firearms? Or is there some correlation with owning the firearm in the first place?
It all depends. I mean, we certainly know that firearms are the number one method choice in the United States. It's hard to walk back an attempt with a firearm. It's so lethal. A couple of decades ago, maybe 15 years ago, in China, the mainland China, women in rural parts of China had greater suicide rates than the men. And it was all connected to pesticides, very, very lethal pesticides that were readily available. And then they contained their pesticides, and that gender difference went away. But never before in the history of the world were we aware of women having a higher rate of suicide until that time in China. So access to lethal means, Governor, is a big concern for suicide prevention folks. And for us, that really amounts to issues around guns.
There's a correlation between substance abuse and suicide rates. How does that work?
Well, anybody that's high or intoxicated and teetering or struggling, ambivalent, is much less ambivalent if they're impaired. If they have ready access to lethal means, like hanging or jumping or a firearm, they're much more vulnerable when they're impaired. So it doesn't always go hand in hand, but it certainly increases the risk. And of course, not lost on you is the big conflation of opioid overdoses that we've also seen in recent years. And a lot of those in the suicide prevention world are thought to be possibly hidden suicides where the people were kind of gambling with very sort of toxic opioid, fentanyl and the like, and ending up dead. So we have certainly wondered about that sort of that interface between opioid abuse and use and overdosing and our suicide rates.
Or is the substance abuse an indicator of an instability, which might be a precursor to suicide in the first place?
It could be. And we certainly know during the pandemic that we saw across the nation and across age groups increases in substance abuse, increases in anxiety, increases in depression, and increases in suicidal ideation and serious thoughts of suicide. So, we did have that dip in 2019, 2020, or 2021 and 2019, 2020, which really got us excited because for the first time in decades, we thought maybe we were trailing off with increased awareness and research. But it still seems to be challenging for us to really kick this down.
The increase on mental health problems for young people is really shocking. And let me ask you this first. On the numbers, according to the NAMI, National Alliance on Mental Illness, an estimated 20% of teenagers have or will have a serious mental illness. 11% live with a mood disorder like depression. 10% live with behavioral or conduct disorder. 8% with an anxiety disorder. 50% of mental health disorders begin by age 14. Over 1/3 of teens with mental health disorders drop out of high school. Among those from 10 to 24, suicide is the third leading cause of death. Is it that young people are more comfortable admitting to a mental health problem? Is it a generational issue? Uh, Old timers like me, when you said a mental health problem, that suggested you had to be institutionalized. Is it that they're just more comfortable with admitting these issues, or is it real, or is it a combination?
Yeah, we're not certain. I can speculate and say that, it's not unusual for any generation to say, never before have kids today faced the challenges that we face. I remember that growing up in the 70s and the 80s. That was a lot of what the older generation was thinking. That said, never before have we had the internet, social media, access to information. The field of suicide prevention is relatively young. Clinical suicidology, which is what I consider my area of expertise, is about 50, 60 years old. And so there's a growth in our knowledge base, Governor. There's a growth in our awareness. And I do believe there's been a tipping point in public awareness. A podcast like this you would have done 10 years ago. It was just not done. And so I think there's good news in all that. But there's also increased awareness. What I think a lot about, Governor, is the practicum that I teach here at the university this semester, for example. I would say 90% of the college students that we see here at the University Counseling Center are anxious. And 30 years ago, when I first started out in this business, we would see a lot more depression in the college students in the same counseling center. So we do see cohort shifts and differences, and anxiety seems to be especially ubiquitous and problematic for young people today. And one of the things you alluded to, which is really critical, is that young people of color in particular are struggling with suicide in ways that are novel and alarming, to be sure.
What's the line between anxiety issues and depression?
They're two different clinical entities or diagnoses, and they oftentimes go hand in hand. Depression can be kind of deflating, and there's a dysphoria, and people feel sad and down. Anxiety is more activating. It involves different parts of the brain and different parts of, they're experienced differently. But one of the things that we think a lot about in suicide prevention and as a clinician that I think a lot about is what we call dysregulation or agitated states. And a difference between a dysphoric depression where somebody's sort of depleted and has low energy is in some ways less alarming than somebody who's got an agitated depression or kind of spinning up where they're losing control, they're out of control, they've lost what we call prefrontal cortical control, and they're just being sort of activated limbically. And that's just a fancy way of saying that people get really upset, and when they get upset, they do impulsive things. And so, to me, a big concern is what contributes to the ubiquity of anxiety and agitated states that I think we're seeing in young people today. That I feel like when I think back to high school or days of my youth, we were not aware of people self-harming, people with eating disorders. It does seem like we've increased our awareness about a lot of these conditions. And there's a good part to that, and there's also maybe some problems connected to that as well.
Going back to your point about growing up in the 70s, 80s, etc., are young people today under more stress? They talk about social media, they talk about academic pressure, they talk about the COVID trauma, more substance abuse issues. Do you see any of those as factors?
I think there is evidence, Governor, that we have seen increases in some of those considerations. I teach a senior seminar of our graduating seniors. So these are 20, 21-year-olds, and they're the ones who really, in their junior year of high school, were boom, hit with COVID, were isolated online, learning loss, writing issues. And so we really lean into that to look at that, Governor, to really try to think, is your experience that much different than adolescents of 5 or 10 years ago before the pandemic? And I would say to some extent it is. Um, but the research, I think, does confirm there's always been challenges in adolescence. Famously, Sturm and Drang, and Freud and people forever have been talking about adolescence as this challenging period of autonomy versus separate, versus dependency, and that tension that kids experience. That has always been true. But there are some unique challenges. One of the things I can say in the research that we do, Governor, where we're studying college students and teenagers, is among things that we assess, we ask them about their reasons for living and dying. And never before in my career have people said, the earth is dying. I'll always be in debt. Our political life. Social determinants that I would say for sure, and we're going to actually study this with a cohort of earlier college students to see if in fact those observations are valid. That social determinants, these large social issues, these large world issues, are weighing heavily on young people today.
Well, the problem is they're right. I mean, if you find out those are factors, doctor, then the problem is going to be they are correct. The earth is dying. Yeah, they're going to inherit a planet that is unstable at best, and the damage is already irreversible. Student debt has never been as pressing. And that's true. The polarization that we have, the dysfunction we have in society, that is all true.
Yeah. Well, it's weighing on them. I mean, when we're clinically trying to treat young people like this, we can't treat polarization of our politics, but we can talk about what they can do within their sphere of influence, and that those are effective interventions. But what I'm saying to you is, I've never before seen young people who are so preoccupied with these large, national and worldwide issues as the young people that we're seeing in our trials.
Yeah, that's a very interesting point. They're more aware of them, and they feel more connected to them. Yeah, old timers like myself, we didn't have those issues, right? Uh, as I mentioned before, you're the creator of CAMS, Collaborative Assessment Management of Suicide, which is a clinical intervention. Can you talk more about that approach, how that might be helpful?
Yeah, so it's really different than what most people get who are suicidal. What in our culture and our medical care system writ large, I think what we mostly see are people going to the hospital and taking medications. And ironically, Governor, those interventions might help some people, but they're not evidence supported. Medications can be very helpful for psychosis and anxiety, but specific to suicidal ideation and behavior, medication doesn't always help, and sometimes it makes things a little bit more challenging. So our intervention is really about trying to keep somebody out of the hospital who might have suicidal thoughts. And to do that, we collaborate with the patient to understand who, what, when, where, and how they have these thoughts. And then part of the treatment involves saying to them, what makes you want to take your life? We call these drivers. And in the intervention, we treat drivers. And overwhelmingly, Governor, the drivers are focused on relationships. They're focused on vocational issues. They're focused on how people feel about themselves. And they don't often ever say the lack of serotonin at the synaptic clefts of the neurons in my limbic and prefrontal cortex. They are work-love struggles that all of us are aware of. And we can treat those issues very effectively in 6 to 8 sessions in this intervention to keep somebody out of the hospital, decrease their suicidal ideation, increase their hope, and help save lives.
9% of young people say they attempted suicide. Uh, what percent of the 9% do you think really had the intention of committing suicide versus an attempt that was a cry for help, etc.?
It's a great question, Governor. It's a little bit in the eye of the beholder. I've interviewed teenagers who held like a butter knife to their forearm and called that a suicide attempt and then backed away, versus a teenager who looks down the barrel of a 22 and tries to get the nerve to pull the trigger, and his mother calls him to go off to basketball practice. In the former, the patient saying that was a suicide attempt, where objectively, technically, probably not. In the latter, much scarier, much more lethal behavior where the teenager didn't see it as a suicide attempt per se. So a lot is in how people construe it. And when you think about young people or children, which people don't think about, even 5, 6, 7, 8-year-olds are talking about suicide. And a lot of adults think, how can you even think about suicide? You're a child. And so a lot of our intervention in the CAMS approach is to get the perspective of the patient and not to know for them what's in play, but to ask them and help them unpack that and then treat the drivers that they identify.
Yeah. Young people, preteen, teen girls, young women, have a significantly increased percentage of mental health issues. Is that new, novel? What's driving that?
That's new data and concerning. We see emergency department visits going up for these young people. We actually, in the most recent CDC data, saw some dipping in some of the behaviors for the children, but the adolescents and these young adults are struggling. And so everybody's speculating. A lot of people that I talk to are thinking, oh, it must be social media. Must be that they're being bullied online. We see that. We see that as a driver, with the teenagers that we see in our clinical trials, where they're being tortured, by peers in a very cruel way online. But we also see rescues that are affected through online, mediums as well. So I'm not ready to write off social media as the cause and the scourge of our young people today. Certainly is a contributing factor, but we also have technologies. We have an intervention called Jasper Health, where you come to the emergency department, and after an initial intake, you sit down with this tablet for up to 4 to 6 hours while you're waiting for the doctor, who shows up 12 hours later. And through this tablet-based intervention, people get calmer, they learn skills, they can download things to their smartphone that they can take with them. There are aspects of technology that can be helpful. It's not necessarily the cause of all of our challenges these days. It's in the mix, but we don't know the causality aspects of it just yet.
Young people are more aware of the issue and more willing to admit the issue, which is a good thing.
Yeah.
Have we done enough to institutionalize or culturalize mental health education into our basic systems? Like, shouldn't we reach a point where it's almost a part of the basic core curriculum? If it's that widespread and if it's that acknowledged?
Absolutely. And are we doing it? Probably not. I would like to think that my sort of vision for this would be like health. Like when I was in high school, maybe when you were in high school, we had a health class where we learned some very basic things about hygiene and so forth. We could have a mental fitness or a mental health component to that. And some schools are doing this. Of course, a lot of this gets quickly politicized, as you can imagine. You of all people can imagine that, I'm sure. These things become seen as intrusive and not respecting parents' rights to raise their kids. I'm in favor of something that is a curriculum that focuses on coping strategies and skills that apply to teenage pregnancy or to substance abuse or to suicide or self-harm behaviors. If kids were learning about different kinds of skills and coping strategies, then they can apply them to the challenges that we all faced in adolescence.
Besides institutionalizing it in schools, et cetera, are mental health services accessible enough? Are they covered in health policies? Are they in the health plans?
Not sufficiently. So we have mental health parity as the law of the land. We have that very rarely as a reality with our healthcare plans. So Patrick Kennedy, among others, is fighting for mental health care parity so that it would be treated commensurate with physical fitness or physical health coverage in our health plans. A lot of people that I talk to assume that hospitalizations and medications must do more than they do. A 3 or 4 day hospital stay is very disruptive. And outside of getting some medication, there's not a lot going on there. And then what's fascinating and exasperating to me, Governor, is so many mental health professionals do not receive training in the assessment and treatment of suicide risk. It is not routinely a part of curriculum in medical school, professional training programs across disciplines. Most clinicians learn about working with suicidal risk by having a patient, in an internship or a residency or something like that, and then figuring out what to do. And then a lot of clinicians work very defensively because they're so afraid of malpractice. So it's a scourge, I think it's a scourge that we have clinicians who are paralyzed by the threat of malpractice. So they're doing defensive practices. They're hospitalizing people who can be readily treated on an outpatient basis very effectively with interventions, including my own, that have been proven to be effective, but are not widely used. So it drives me a little crazy, to be honest. We're really trying to, drag the field into using evidence-based approaches and not doing just what we've always done, which is to hospitalize people and medicate them.
Yeah. They have an app for everything now, and there's a lot of technology companies that are talking about mental health apps where you could download an app, you could get counseling online, sort of almost an AI version of mental health counseling, right? You could input your symptoms and you'd get a response, or you'd get counseling online, not by a person, but
Yeah,
pure technology. What do you think
yeah.
of that?
I'm in favor of everything. So, the way I look at it, Governor, is that we have 15,600,000 American adults and teenagers with serious thoughts of suicide in 2021. That is 300 times greater than the number of people that die by suicide. As much of a concern as that is, we have an iceberg of people who are suffering and struggling, who many mental professionals just see as like, oh, well, they haven't made an attempt or they haven't died by suicide. We shouldn't be concerned about them. We should absolutely be concerned about them. If we were better identifying them upstream and treating them there, fewer go on to make attempts and fewer go on still to die. So I was a proponent in 2016 when we were trying to work with the losing presidential candidate to develop a mental health service corps, to develop a Peace Corps level initiative that would person up our national lifeline. We had problems with the lifeline with a number that nobody could remember in terms of capacity. Now we've got 988, which is great, a big policy win, but there's a 40% increase to Lifeline, and we have capacity issues. What we need is for young people lived experience, loan forgiveness. It would be like in my view, like a Peace Corps level initiative to build an army of people who could be trained in safety planning, lethal means discussions, person the Lifeline and the National Text Line. Because with 15.6 million, we've got a lot of people who are suffering and struggling.
Yeah. Here's to end on an optimistic note. I think there is a silver lining in the fact that young people are so aware of it and they're willing to talk about it. And I think generationally, whereas my generation, even younger generations, this was a verboten topic, mental health. And literally, it would suggest institutionalization, so you would never admit an issue. You were just uncomfortable with the entire topic. The fact that they are so fluent with it, they have friends who are dealing with it, friends who are dealing with it openly. As that continues, as they grow up, if you will, I think that'll bring a greater awareness into society. And with a greater awareness will come more resources, more creativity, more institutionalization in terms of culturalization in our schools, etc. That's my hope, anyway.
I share that hope, Governor. What I can tell you is in our clinical trials, we increasingly have young clinicians who aren't even licensed working in these trials. They don't have attitude. They care about the evidence. They just want to help people.
Yeah.
People my age, they're much tougher to train. And so I share your hope and your excitement about the possibility of, from a generational standpoint, increased awareness and people catching up with the evidence base of what actually is being effective in caring for folks is going to, turn the tide and make a difference.
Even the concept of wellness now. the connection of what you eat and your mental state and your physical state all being linked. Even that conversation is different than years past, and I think is going to be positive. So uh, while the numbers don't look good, and there's no reason to think that the numbers are going to change immediately, I think long term, my prognosis is we'll make improvement, doctor.
Me too. I appreciate the chance to talk to you about it.
Thank you for what you do. Thank you for all the good work. And thank you for the lives that you literally have saved. We're all in your debt. Thank you very much.
Thank you, Gilmore.
Good
I
to be
appreciate
with
it.
you, docs.